Welcome to the University of Michigan Dentistry podcast series, promoting oral health care worldwide.
Functionally generated occlusal registration is not a new concept. In 1932, Meyer was presenting postgraduate courses in a chew-in technique for complete dentures. This technique is acceptable for prostheses that requires a fully balanced occlusion. Unfortunately, functionally generated occlusal registration procedures for fixed prosthodontics are many times equated to the term chew-in and combined with a mush bite to produce a technique that merely reproduces an oft-time incorrect existing occlusion with bizarre occlusal morphology. Like any other technique or concept, the operator's understanding of the full potential and limitations of the procedure will be directly reflected in the end results. Functionally generated occlusal registration is a technique for recording border pathways directly in the mouth. The pathways are directed by the four determinants of mandibular movement. There are two posterior and one anterior determinant. The posterior determinants are the temporal mandibular joints and their associated suspensory ligaments. The anterior determinant is the interocclusal contacting points plus the cusps of the opposing dental arches. The fourth determinant of mandibular movement is the neuromuscular system that motivates the mandible to action. The first three determinants constitute the anatomic centers of mandibular movement. The only segment that the dentist has direct control over are the guiding planes of the contacting teeth. It is apparent then that unless the operator wishes to perpetuate the patient's existing occlusal morphology, these planes must be changed either by selective grinding or procedure of reconstruction of the anterior guidance prior to rebuilding the posterior occlusion. The first decision, whether the morphology and relationships should be changed or maintained, is necessary. The patient that has a stable occlusal relationship and the absence of disease of the gnathostomatic system will, in all probability, accept a restoration with occlusal surface contours produced from a functionally generated occlusal registration of the existing dentition. The patient that presents with occlusal instability should be corrected. Also, temporomandibular syndrome must be diagnosed and treated prior to the restoring of the dentition. Assuming the occlusion has a stable situation, the next decision that is to be made is what concept is to be followed. Whether a point-centric or long-centric concept is selected, the balance of the dentition must be made compatible with the proposed restorations. With these prerequisites satisfied, we can proceed with the preparation of the dentition and the functionally generated occlusal registration. For our laboratory demonstration, we have elected to do a lower posterior 3-unit bridge. And we will consider this our patient, and our patient's dentition has been stabilized, and you will note that we do have cuspid guidance that discludes the posterior dentition. And before we start our preparations, we will ascertain that we do have a positive contact on the areas that we are going to prepare and also on the opposite side of the mouth. So using some 5,000 shim stock, we'll check our contacts on our abutments, and we do have contact in these areas, and also we'll check several key teeth on the opposite side of the arch that we'll use as we proceed for reference. And we have contact on the molar, and we also have contact in this cuspid area. And this side also has cuspid guidance in disclusion in the lateral excursions. We'll now proceed to prepare the lower bicuspid on this side of the arch. We have now prepared our bicuspid and our molar teeth, and prior to taking our functionally generated registration, we would like to establish an interocclusal registration so that we may articulate our anatomic and functionally generated core as we proceed through the technique. A way that works very successful with this particular technique is to take either a standard aluminum shell crown, as we have done here, and cut it down so that it fits a tooth well at the cervical area, and cut a hole in the occlusal surface, as we've done here, to allow some of the acrylic to be expressed through, or to use a copper band. The hole allows us to register the opposing cusp in the acrylic material and subsequently rearticulate our casts. So we will now mix up a bit of cold cure acrylic, and the type is not too critical. We could use Duralay or any of the other materials that are available for techniques similar to this. In this particular instance, we're using a material called TMJ acrylic. The one advantage of this particular material is it's got a diatomaceous earth filler in it, which takes away much of the rebound and memory that's inherent to most of the acrylic materials. And for making the platform especially, it seems to be very well suited for that particular purpose. We'll fill our little shell crown with the material, and when it's lost its gloss or gone through the stringy stage, we'll insert it into the mouth. The reason for allowing it to proceed through the initial stage of set is so that the patient will not be subjected to as much free monomer. However, in this instance, we'll place it on the articulator almost immediately and seat it down into place and remove the excess amount that's expressed here, and continue to seat it until we get a relatively small amount of material expressed through the opening, and remove any of the excess material that was expressed around the margin with a suitable instrument, so that the soft tissue is not subjected to any undue contact with the free monomer of the acrylic. And when it attains its proper consistency, we will instruct the patient to close into centric occlusion in this particular instance and register an opposing cusp in the material. And here you can see that we have registered an opposing cusp in the material, and this is more than adequate amount of articulation with the opposing cast to allow us to get a very stable interocclusal relationship. When the material begins to polymerize, we will remove it so that we do not damage the pulp, and then we can check those key teeth again, which we checked originally with our shim stock, to make sure that they are still in occlusion. If for some reason or other we have not completely seated this, or we do not have an absolutely accurate relationship so that we do have teeth contacting as we did originally, we can cut a small amount off of the occlusal surface and go back and do a wash with one of the ZOE materials so that we get a very accurate registration. And again, check those key teeth to make sure that we do have a contact as we did originally. And then we will use this, as I say, subsequently to mount our anatomic and functional cores. We are now ready to make our platform for our functionally generated registration, and again we will be using the TMJ acrylic material for the reasons previously stated. We've begun to mix it already, and we'll have to wait till it establishes itself to a little more solid consistency, and then we'll make it up into a rectangular shape and place it over the teeth and instruct the patient to close into centric occlusion. In this particular instance, if the dentition had been stabilized in centric relation, obviously we would use that as our starting point, and we can handle our material now and make it up, as I say, into a rectangular shape. We don't need too terribly much of the material, and place it over the teeth and mold it to shape with our fingers. And you can see that much of the memory that's normally found in the acrylic materials is absent with this particular acrylic, and instruct our patient to close into centric occlusion. And then we can mold this along the buccal surface, have the patient open, and mold it a little better on the tongue side. And again, we will take necessary precautions so that damage is not done to the teeth as the material polymerizes. We can intermittently keep our finger on the material to make sure that heat is not generated, or we can instruct the patient, if the patient is not anesthetized, to let us know when they first feel the first amount of heat being generated. While this polymerizes, we'll show you a platform that was done previously, and here you can see the outline of the opposing dentition. We have marked the areas where the maxillary lingual cusps have registered in the acrylic. This will be important with the direct technique. Now, with the indirect technique, we'll simply cut the occlusion down on this platform so that there are no contact with the opposing arch. With the indirect technique, which we will discuss later, these articulating points must be preserved, so it would be a little more judicious cutting down with the indirect technique to preserve these stops. We will cut the platform down to the point where only the registration is shown here, and relieve it on the soft tissue so that there's no impingement on the soft tissue, and we can reseat it precisely. We'll now check this material to see if it has attained enough body so that we can remove it. It's just going through its polymerization stage. I'll try to tease it off here. Yes. And here you can see that we get quite an accurate registration of the preparations in the material. And as we previously stated, here's the occlusal surface with the maxillary arch registered quite accurately. After we have done this and trimmed down our platform, as we showed you previously, we can apply the wax into which we will generate our functionally generated registration. And in this particular case, we are going to use a material called Bosworth's synthetic tacky wax. It's a soft red material which is much like utility wax. There is another wax on the market which is made specifically for this purpose also, made by Jelenko Corporation, called Hi-Fi wax. So we'll now apply wax to our platform. We will be applying the wax primarily to the periphery of the platform, inasmuch as this is where the wax is normally pushed during the functionally generated registration. After one has done several of these, we can pretty well gauge where the wax will be moved to, and by putting the bulk of the wax in these areas, it does save some time and generate a better registration. Now we'll continue on laying our wax around the periphery of where the teeth are until we've built up a sufficient amount, and then we will transfer that back into the patient's mouth, and we will be ready to do our functionally generated registration. We've now applied a sufficient amount of wax to the platform, and with the direct technique which we are now describing, we will cement the platform directly into place in the mouth, and we can use one of the temporary bridge cements, and here we're going to use some temp bond, and we'll just add a sufficient amount around the peripheral edge of the teeth to stabilize the platform in the mouth and in place. The reason for doing this is to be sure that we have an absolutely stable platform and that we have a registration which is as accurate as we can possibly make it. Obviously, if we're going to cement this into place, it precludes the indirect technique, which we will subsequently describe, since it would be difficult to remove this platform intact from the mouth. The advantage of the direct technique over the indirect technique is that we've eliminated one potential source of error, and that is the transfer of the platform to the dies for subsequent registration of the stone functionally generated key. We are now ready to do our functionally generated registration. We've placed it into the patient's mouth, and we would normally allow the cementing medium to harden. And then we would instruct our patient to close, in this instance, in centric occlusion. And if the dentition had been adjusted to a long centric, we would move them from centric occlusion to centric relation, and then through the lateral excursions, and first to the right lateral and then to the left lateral. Unfortunately, our cement has not completely set yet, so it will be necessary to use a bit of caution. You can see that the wax does have some adhesive quality to it, so it is advisable to cement it into place. Having the patient go through their lateral excursions first, now the opposite side, chewing in, registering the dynamic movements in a static registration. Now into protrusive, and here you can probably see some of the wax being wiped out of the position that it was set in, and then instruct the patient to chew as if they had a bolus of food in their mouth, so that we might capture any eccentric movements that we didn't capture in our guided lateral and protrusive excursions. And this is approximately the amount of time that would be required to get a good functional registration. We'll remove the upper member of this articulator. Remember that this was our patient, so that we can see our functionally generated registration a little clearer. And here you can see that we have registered the dynamic movements in the wax, and you can still see the indentations or the marks that we put on the platform prior to the time that we started of the lingual cusps of the maxillary arch. We're now ready to prepare our tray and do our direct pickup in the mouth. We're now ready to do our direct pickup in the mouth, and we've taken a stock disposable acrylic tray and cut the flange down, as you see here, and also remove the handle. And this we'll use to make our stone key registration of the functionally generated registration directly in the mouth. We're going to use a material called gray rock stone, and this sets quite rapidly, Unfortunately, some of these quick-set stones, after they've been on a shelf for a period of time, you lose some of the quick-setting properties, so that it is necessary, as we use this material up, to use either slurry water, which we're using in this particular instance, or warm tap water. Because of the warmth of the television lights, we'll mix this to a more fluid consistency than what we would normally do under an operatory situation. And after we have mixed the material, we'll take a paintbrush and apply a sufficient amount over our functional chew-in so that we get a good bubble-free registration. Normally this stone will set up in approximately 2 minutes in the mouth under normal conditions, and paint all of the areas, being sure that we work it in so that we get good detail with an absence of any bubbles or voids, because this will be what we will subsequently be using to generate our occlusion in this area. And the more crisp registration we have, the better the final registration. I have mixed this a little more fluid than what I really would have liked to have had it, but we'll utilize it as is. It should set quite rapidly, and it will cause the patient no discomfort because it does not generate any appreciable amount of heat. We'd hold this tray until the material had attained a little stiffer consistency than what it is right now, and then our objective is to just register the occlusal surfaces of the rest of the dentition and pick up our functionally generated wax registration in stone on the opposite side. We will have to wait just another moment while this attains a proper consistency. Take it into the patient's mouth, and again, this is just a little more soupy than we would actually like to have it, and place it on top of the teeth like so. Gently place it and allow this to harden. Our stone is now set, and we can remove it carefully from the patient's mouth. See that we did not distort it. And here you can see that we have registered our functional chew-in in stone and the balance of the dentition. We have registered more of the occlusal surface on this balance of the dentition than we would normally like to capture. All it's necessary is to have enough of the occlusal surface to allow for us to position the stone key back onto the articulated model without it rocking. So now we will transfer this stone key over onto an articulator, and in this instance we're using a Hanau Model H. Really the only prerequisite for an articulator is that it be able to reposition the centric positioning, and also have some type of a quick interchange between the stone functional key and the anatomic model. We've placed our aluminum shell crown on the molar that we took previously, and this we will use to establish our interocclusal relationship. So now all that's necessary is to reposition the stone key onto the articulator, and here you can see it's quite stable, and attach it to the upper portion of the articulator, and this will give us our functionally generated key. We would also like to have an anatomic cast positioned on the articulator so that we can develop our buccal contours, and here again we will use the aluminum shell crown and use this to mount our anatomic cast, and again you can see that it's quite stable. After we have these two casts mounted on the articulator, we're ready for our wax-up procedures. You will recall we stated for the indirect technique that it was important that we maintain the stop areas generated by the lingual cusps of the maxillary teeth. The reason for this is when we take the functionally generated wax platform out of the patient's mouth and transfer to the articulator, it will be necessary to reestablish this relationship between the upper and lower member. And by having these centric stop areas in acrylic, we can close the anatomic cast down into the functionally generated registration without distorting the wax. So we'll now take the functionally generated wax platform from the patient's mouth, and here for this technique we did not cement it to place. So we must be very sure that our platform is stable without the cement to add to its stability. So we'll now transfer this over onto our articulator, and we have already mounted the upper anatomic cast utilizing our small bite that we generated previously with the aluminum shell crown. We'll place our platform onto our fabricated dies and close the anatomic cast into the wax. And you can see that if we did not have the stop areas in acrylic, we would distort the wax. We would now utilize our shim stock to check our key teeth to be sure that we still have the proper relationships, and we would box around the platform and pour our stone core. Here you can see a side view with the square boxing wax in place and the occlusal surfaces of the teeth exposed. The boxing wax eliminates the stone from running down the buccal and lingual surfaces and locking itself to place. This slide illustrates an occlusal view. You can see the exposed occlusal surfaces and the functionally generated wax platform. Our first pour of stone is dry, and you can see we left some small nubbins of stone so that it will lock itself well into the subsequent amount of stone that we will put on to attach it to the articulator. And again, an occlusal view showing the small nubbins of stone and the first pour. We are now ready to attach this to the upper member of the articulator. And this is our finished stone key, and we've outlined the functionally generated path area in black so it will be a little more readily discernible. And this is approximately the correct amount of registration that we would like on the balance of the dentition. We've now mounted our anatomical cast, and our functionally generated stone key has been prepared and mounted with a ring so that we can index this on the articulator, and now we are ready to send our case to the laboratory for the waxing and casting procedures. Functionally generated occlusal registration generates a negative pattern of the opposing dentition. It follows logically then, rather than try to carve back the wax to match it, the wax should be built up to meet it. In order to do this, we must understand the component parts of occlusal anatomy of the tooth and the role that they play in function. The occlusal surface of the teeth are made up of elevations and depressions. The elevations are the cusp tips, marginal ridges, and trigonal ridges. The depressions are the fossa areas, the developmental and supplemental grooves. The supportive cusp tips on this particular tooth are the buccal cusp tips, represented here. This first lower molar has 3 buccal cusp tips. And we have the central fossa area, which is also supportive for the opposing dentition. On some teeth, we also have a fossa area in the mesial and on some of the bicuspids in the distal areas. The non-supportive cusp tips, or idling cusp tips, are the lingual cusp tips on this particular tooth, represented here and here. Next, we have the fossas. Here, the central fossa, extending both mesial and distally. And we have the non-supportive cusp tip marginal ridges, indicated here. And this will extend the entire periphery of the tooth into the mesial and the distal marginal ridge areas, around to the buccal surface of the tooth, to the mesial and distal marginal ridges of the buccal cusps, as represented here, around the entire peripheral area of the tooth, as shown here. Next, we have the axial contours of the tooth, which will probably extend down to an area in this area, where we will begin to pick up the contour of the residual of the preparation and blend this in to the marginal area. This is also extremely important, although it doesn't play a particular role in the function of the tooth. It does throw the food off of the tooth surface and stimulate the gingiva so that we have a healthy overall dentition. We next have the triangular ridges, and they gain their name from the fact that they are triangular in shape, starting from the cusp tip down into the central fossa area. And here you can see they begin to take a triangular shape, thus the name triangular ridge. And on either side we have a supplemental groove, as represented here. And then further we have the sluiceways, which allow the teeth to pass across one another without interfering. Here we have a developmental groove or escape way for the opposing cusp, similarly here, and similarly in this area on the buccal surface. This completes the occlusal morphology of the tooth. The height and position may be dictated by function, but it also may be dictated by the ideal morphology of the tooth if it's a non-functional portion of the surface. We'll see the tooth built up on a series of models that will represent starting from the cusp tips and then progress through to the completed occlusal morphology. On the first series of models, we'll see the cusp tips. The non-supportive cusp tips on the lingual aspect of the tooth are now built up, and we also have the central fossa supportive area that was indicated on the first model. Next, we see the development of the marginal ridges, mesial and distal, buccal and lingual. This encircles the periphery of the tooth and leads to the next step in the development of the occlusal anatomy. Next, we add the triangular ridges, some of the supplemental grooves and escapeways, leading to the final step, which is the perfection of the occlusal anatomy with the supplemental grooves and the details to render the completed occlusal surface of the tooth. Now, with attention to a few of the minor details, the supplemental developmental grooves, etc., we end up with an occlusal anatomy which is not only functional but aesthetically pleasing to the eye. This you can see as a logical way to start with the supportive, non-supportive, marginal ridges, triangular ridges, and on through the occlusal development, ending up with a harmonious occlusal anatomy which will be acceptable to the dentition.
We are now ready to begin developing our wax pattern. And I'd like to direct our attention first to the maxillary cast, where we have marked the potential centric stop areas. The orange dots represent the centric supporting cusps of the bicuspids and the molars. And the black dots represent the centric stop areas which will be developed against the mandibular supporting cusps in the first step of our waxing procedure. This procedure will have 6 steps, so let's first off take the first step. We will be using the Peter K. Thomas waxing instruments, using the number 1 waxing instrument and red wax. We will begin to develop the centric supporting cusps of the mandibular teeth. These will articulate into the black dot areas on the maxillary cast. It's nice at this time to have your flame and all your wax relatively close to each other, so your finger rest positions and your arms don't have to reach across the table very far to reach the wax or the heat. So the heat leaves the wax relatively quickly. We'll go ahead and develop all of our mandibular supporting cusps in red wax first. We've now completed step 1 by adding the red wax, dusting with zinc stearate, closing the articulator to ensure that we have contact in the black opposing cusp fossa areas on the maxillary cast. Our second step will be to develop on the mandibular teeth centric stop areas for the maxillary supporting cusps. And to do that, we've outlined with black pencil the potential areas where these cusps will articulate. And now, again with Peter K. Thomas waxing instrument and some red wax, we will develop these centric stop areas on our mandibular platform. We're using a little template here, or platform, if you will. In a clinical procedure, you may use one of these, or you may have just a skin of wax over the dies. We will then again dust this with zinc stearate, close the articulator to ensure that we have these positioned in the proper relationship. It's most important at this stage, when working against the anatomical cast of the maxillary arch, to be sure we have these cusps positioned exactly where we want them, because the rest of the waxing procedure will depend upon positioning of these cusps and supporting cusp areas. We'll now dust this with some zinc stearate. And again, close the articulator. We've now completed steps 1 and 2, the development of our centric stop areas and centric cusps on the mandibular template. And we'll move on now to step number 3, which will be the development of the non-supportive lingual cusps. To ensure that we don't get mixed up in what area is what, we're going to use a different colored wax. In this case, we'll be using white wax to develop the non-supportive cusps. It's most important here to keep these cusps as widely separated as possible. Don't get them too close to each other. We We will again then dust the surface of the wax with zinc stearate. And close the articulator to make sure that we don't have any interference with the anatomical opposing cast. After completion of the entire wax-up, we will then articulate it with the functionally generated stone record that we made in the mouth. So we'll go ahead and complete these non-supportive cusps at this time. We've now completed step 3, the non-supportive cusps, those being the lingual cusps, the mandibular molars, and the bicuspid. And we'll now move on to step number 4, which will be the development of the marginal ridges and the cusp ridges, each cusp having a mesial and a distal cusp ridge. We'll switch colors here and go to green wax to further emphasize the differences between each of these parts. We're using a green wax called Neal's wax. It's a very nice wax to work with. And we'll begin developing the marginal ridge areas on our wax pattern. This has been called the fish mouth part of the procedure. As we develop this, we'll also be developing the mesial and the distal cusp ridges for each of our supporting cusps. We'll go ahead and complete this step, and we'll come back for step number 5. We've now completed step number 4, the development of the marginal ridges and the cusp ridges on our mandibular wax-up. And we'll move on now to step number 5, whereby we'll be creating triangular ridges. You'll recall that the triangular ridges run from the tips of the cusps down toward the central developmental groove of the tooth. Here again, we'll be using some green wax to form our triangular ridges. And each time an addition is made, we will again dust the area with zinc stearate, close the articulator to ensure that we do not have any interference. It's good to recall that the shape of the triangular ridge is somewhat of a teardrop, with the base being wider down toward the central developmental groove than the area near the tip of the cusp. We'll go ahead and complete these triangular ridges, and therefore complete step number 5 of our wax-up. We've gone ahead now and completed step number 5, the triangular ridges, and we've again dusted the surface with zinc stearate, closed the articulator to ensure that we still have our centric stop areas that we started with, those areas that are in red. We'll now go on to step number 6, the final step in our waxing procedure, and show the development of the supplemental grooves and the supplemental ridges. Supplemental grooves run from the central developmental groove and flank each of the triangular ridges. These are best developed with the Peter K. Thomas carving instrument and with the Peter K. Thomas waxing instruments, recalling that each one of the developmental grooves is flanked by a supplemental groove. This then completes the anatomy of the tooth. We will now go on to the articulation of our wax-up with the functionally generated stone record. Graphically, we can see the wax-up at the stage we have it at the present time. However, if we were to articulate this with the functionally generated stone record, we may well have conflicting areas, both on the balancing and on the working cusp inclines. Graphically, this is depicted in the areas of the yellow arrows, the one on the left being the balancing incline, and the one on the right being the working incline. To check this, we will have to put our stone functionally generated record on the maxillary part of the articulator. Illustrated graphically, the yellow area highlighted represents wax which may need to be removed to prevent a balancing interference. This area of our wax-up would be the lingual incline of a buccal-mandibular cusp. In addition, this area, now being highlighted, also represents wax which may need to be removed to prevent a working interference. Now returning to our models, we have placed our functionally generated stone record in the maxillary part of the articulator. We've also dusted our wax-up with zinc stearate. We'll now close the articulator to verify whether or not any of these interferences, which we have just graphically depicted, are present in our wax-up. Close examination of the wax-up does reveal that on the mandibular pontic and on the mandibular second molar wax-up, that a balancing interference is present. These are on the lingual inclines of the buccal cusps. After removal of these interferences, our wax-up will be ready for spruing and casting. We've now removed those interferences on the lingual inclines of the buccal cusps of the molar and the ponic wax-up. You'll want to also go back and repool the centric stop areas. Whenever you carve the wax, there's a tendency to create either a flat surface or a concave surface. And rather than having that, you want a convex surface in the wax in the final casting, therefore also in the wax pattern. So now, following removal of these interferences, the wax pattern has been cleaned up. You'll want to readapt your margins, pull the pattern, sprue it, and cast it. And then come back with the casting and adjust the casting, not only against the anatomical, but against the stone functionally generated pattern also.
Our patient has presented with a slight prematurity in centric occlusion and a 1/4 millimeter slide from centric relation to centric occlusion. There is no indication of pathology in the temporomandibular joint or the balance of the gnathostomatic system. We have adjusted the prematurity in centric occlusion and elected to leave the anterior-posterior slide from centric relation to centric occlusion in place. We have checked the dentition for stops with the 5000 shim stock and ascertained that we do have a stop in the opposite side of the arch. The teeth have been prepared. We have a full crown on the molar abutment and a 3/4 crown on the anterior bicuspid. We have lubricated the soft tissue on the teeth with a sterile Vaseline material to eliminate any possible contact with the soft tissue and the acrylic material. And we're now ready to mix up our acrylic and fabricate our platform prior to the functional chew-in. We have elected to use the TMJ acrylic, which we demonstrated in a laboratory situation, and we will mix this and allow it to come to a heavy doughy stage prior to the time that we insert it into the patient's mouth. The acrylic has now attained a consistency where we can manipulate it in our hands, and as soon as it attains a slightly more doughy consistency, we'll be ready to put it into the oral cavity and make our platform. As you can see, it's still just slightly tacky, and we would like to have it in a little bit more doughy consistency. And the longer that we can hold this out of the oral cavity, the less chance of causing any irritation to the soft tissue. Well, we're just about ready to apply it into the patient's mouth. Would you open, please? Thank you. And as we demonstrated in our laboratory exercise, we can set this to place and mold it down over the teeth. Now, close together, please. Have the patient close together. In this instance, in centric occlusion, we'll allow this material to attain a little more substantial body to it, and then we'll remove it and replace it several times until it starts to go through its polymerization. The material has now gone through its polymerization state, and during this process we did remove it several times to prevent any damage to the pulp tissue. And here you can see that we have registered the opposing dentition in the acrylic quite accurately, and we will mark the lingual cusp tips to give us a guide as to how much we would like to reduce this platform for our wax. You can also see that we have registered the detail of the preparations quite accurately in this particular material, which will give us a very stable base after it has been trimmed. The next step in the procedure is to trim the base so that we do have clearance between the opposing dentition and the platform, and then we will apply the wax. But now it will be necessary to, after we have trimmed it, to try it back into the oral cavity and check to be sure that we do not have any contacts on the opposing dentition. So again, using our shim stock, would you close together please, we will check to make sure that we do have clearance, and as you can see we do have clearance on the platform. Again, close please. And we'll go back over on the opposite side of the mouth and close together please, and check and be sure that we have maintained our contacts on the opposite side of the mouth. We can now apply our wax preparatory to doing our functional chew-in. We have now applied the Bosworth synthetic tacky wax to the surface of our platform, and we have also applied some temp bond around the margins of the molar and the bicuspid to stabilize the platform in the mouth. We're now ready to place this into the mouth and do our chew-in in the wax. The advantage of using the temp bond is we get a very stable platform. And close together please, just bite together for me, that's fine. Now we've registered centric occlusion. Open please, fine. And we'll just allow that to set up just another moment, and back together again please, that's fine, good. Open again. We're going to manipulate the patient back into centric relation first. Just come together, squeeze together, good. Allow him to slide up into centric relation, a centric occlusion. Open again please. And we have now registered our centric areas in the wax, and now we will go through our border movements. Back together please. With your teeth together, slide towards me. Slide towards me please, a little further, fine. Now back together, good. Now would you turn your head a little bit to the side, very good. And slide towards me again please. And back together again please. Now in the opposite direction, good. A little further, fine. Back together again please. Now right straight forward please, right straight forward, good. Back together again please, fine. Now chew as if you had a piece of food in there, just chew together, fine. Very good. Open again please, fine. We have now captured our dynamic movements in the wax in a static registration. We will now endeavor to register this in stone to give ourselves a stone key. And we have taken a stock tray, as you can see here, and cut the flange down so that we have approximately 3 or 4 millimeters of flange. This will be all that will be necessary to register the occlusal surfaces. We'll now mix our fast set stone and apply it to the wax in the mouth and carry the tray into the mouth and register the balance of the dentition. We're now applying the functional bite stone to the chew-in, and as soon as we have applied this, we will load the tray and register the balance of the dentition in stone, and this we will use on our articulator as we demonstrated in the laboratory procedure to fabricate our bridge. Rather than using one of the commercial stones, we are using Velmix that has had a degree of anhydrated Velmix added to it to accelerate its set. And utilizing this technique, we can control the set of the stone by varying the amount of anhydrated material that we apply to it. And now we'll place this in the patient's mouth and just register the balance of the dentition on the opposite side. This should take approximately a half a minute to set. The stone is now set, and we have removed the tray from the patient's mouth. It can now be mounted on the articulator, as we have done here, and you can see that we have captured the wax registration in stone on the side of the arch with the detail, and a minimal amount of the occlusion on the opposite side of the mouth, just enough to allow us to stabilize the cast on the articulator. We can now send this to the laboratory and have the bridge fabricated, as you can see here, and it has been checked with the stone key and also the anatomical stone cast to give us our contours. Here you can see the occlusal detail and occlusal morphology. And now, after sterilizing the bridge, we are ready to try it into the patient's mouth and check the excursions. Now place the bridge into the patient's oral cavity, and we will check with shim stock to ascertain where our centric contacts are. And as you can see, we have a facing on the pontic, and we'll have the patient close together, please. Bite together, please. Fine. In centric occlusion. Open, please. Back together once more, please. Good. We have contact there. Open again, please. Back together again, please. Seems to be a little bit light. No, we have good contact there. And back together once more, please. Fine. And just a little bit light in that area. And we'll check our centric stop over on this side. Bite together, please. Good. And we still have maintained that on the opposite side of the arch. Back together, please. And slide towards me, please. Fine. Open, please. Good. We do have a small area of working contact on the pontic, which we would like to relieve. We do have some working contact on the buccal of this bicuspid, which we had in the original dentition, and we have moved our guidance back into the mesiobuccal of the second bicuspid to take some of the lateral force off the first bicuspid. Now check it in the opposite excursion. Back together again, please, and slide towards me, please. Fine. Open, please. And I see no balancing contacts on the dentition. And back together once again, please. Right straight forward, please. Fine. Open, please. Good. And we have no interference in our protrusive excursion. So we would make those few refinements. Back together again, please. And check our centric relation to be sure that we haven't incorporated any trigger mechanism that might elicit a bruxing action, and cement the bridge in permanently, and then instruct the patient. After a week or so, we'll have him return for a final touch-up and any additional adjustments that might be necessary. And turn your head to the side, please. And you can see that we do have a rather aesthetic result. And open again, please. And turn your head towards me a bit. Fine. And we have generated the type of occlusal anatomy which would be acceptable in any particular circumstance.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.